Yes, perfect.
Good evening, fellow doctors and colleagues. For today's Dr. Sheng-Po Hao retirement virtual webinar, we're honored to introduce Professor Umamaheswar Duvvuri as our invited speaker. Professor Duvvuri is a graduate from the University of Pennsylvania, obtaining his medical degree in 2000, 2000 and his PhD in biophysics in 2002. He completed an internship in general surgery in 2003 and residency training in otolaryngology in 2007 at the University of Pittsburgh Medical Center. He completed fellowship training in head and neck surgery in 2008 at the University of Texas MD Anderson Cancer Center. He currently serves as the Mendick Foundation Professor and Chairman of the Department of Otolaryngology Head and Neck Surgery at NYU Langone Health and NYU Grossman School of Medicine. He was previously Director of Robotic Surgery at UPMC and co-director of the Head and Neck Cancer Program at UPMC Hillsman Cancer Center. He is the leader in his field and has proctored transoral robotic surgery cases at numerous medical educational facilities throughout the United States and Europe. Today, Professor Umamaheswar Duvvuri present topic is, can we personalize care for the head and neck cancer patient? Please give a round of applause to welcome Professor Umamaheswar Duvvuri.
Thank you, everyone. Thank you so much, Peter, for the kind invitation. I'm going to share my screen here and turn on the video. Can you guys see that okay? Is that okay?
Yeah, very good.
Perfect. So I thought the topic that I would do here is, can we personalize care for the head and neck cancer patient? And here are my disclosures, nothing of relevance. Sorry, I have one thing from the hospital. Sorry, apologize for that. So this is why we're here, to celebrate Peter. I was lucky to have met Sheng-Po through our mutual mentor, Dr. Myers, who has been a stalwart. And of course, as you all know, Sheng-Po did spent a lot of time, I should say, in Pittsburgh, and through that became a luminary in the field. And I've been privileged to call Peter a friend and a colleague. He's a luminary, as I said, in the field, who has really espoused the development of head and neck cancer surgery throughout Asia, and has taken on the yeoman's work of training people as much as Dr. Myers did here in terms of training the generation of head and neck surgeons at Pittsburgh. And I was lucky to have been a part of that. Not only is Peter a great surgeon, he's an even better person, and lucky to have called him a friend over the past many years. And of course, I would say that affectionately, he's the founder of the Pittsburgh Mafia. Those group of people that have come to Pittsburgh. Bruce, I know you've been there as well. And once you sort of set foot in Pittsburgh in the ENT space, especially the head and neck surgery space, you become a part of the Pittsburgh Mafia. And Peter has been the ringleader of that mafia for many years. And so, Peter, thank you for all of that, and congratulations on an amazing career. And I know this is not the end of it, but rather just a different phase. And so we look forward to seeing that as well. So on to the topic at hand. We know that head and neck cancer is not just one entity, but rather two distinct types, driven, as you can see on the left of the screen, by smoking and chewing tobacco and alcohol use, which are common agents for this causation. And then on the right-hand side now, though, we would say the newer kid on the block, the human papillomavirus, which is a big problem in North America and Europe, but maybe less so in Southeast Asia and Asia in general. But still, I think plays a role in the in the pathophysiology of mucosal disease of the squamous cell. Of course, aside from nasopharynx and recognizing that EBV-associated nasopharyngeal cancer is a large problem in Asia, which I know you guys know better than I do. So HPV positive oropharyngeal cancer, at least in North America and Europe, has overtaken cervical cancer. And this is kind of shocking. So this is now the #1 viral cancer in the world. And this is a sort of a striking problem, given the fact that the human papillomavirus is very, very transmissible, and many, many, many people are exposed to it over the course of their life. Now, we have to recognize that HPV-associated cancers have a very different survival, very much like nasopharyngeal cancer that is driven by Epstein-Barr virus, has a very different etiology and a very different outcome than EBV-negative nasopharyngeal cancer. So these virally associated cancers are, of course, much more sensitive to treatment. And here's some seminal data from Kian Ang, which he published just before his own death, unfortunately, showing that HPV positive or P16 positive cancers have a much better survival and prognosis when compared to P16 negative or HPV negative tumors. And what this really led to is this idea that we needed to de-intensify the care for these patients. And that the de-intensification comes because as we have these wonderful survival, look at this, 80+% at 5 years, these patients live for a very long time. And so their functional outcome is just as important as their survival. I know that you are very acutely aware of this in Taiwan and Asia from the nasopharyngeal cancer population, which is cured with chemoradiation. Now we're trying to optimize their functional outcome. So why are we de-intensifying? Because the 8th edition of the AJCC sought to change this fundamental paradigm of the 7th edition. And in fact, we adopted essentially the EBV staging schema, if you will, in the broadest sense from nasopharynx cancer, and adopted it to HPV positive disease, where instead of having N1A, N1, N2A, N2B, N2C disease, N3 disease, we now have N1 disease for ipsilateral, N2 if you have a bilateral neck disease or large nodes, etc. And then we in fact got rid of N3 from the clinical staging, if you have a surgery. And so there are some subtleties and subtle differences, but really what we're focusing on is that the patients with chemoradiotherapy have really, really high toxicity of 43% or so if they're treated with chemoradiation. And this late toxicity can actually manifest itself in a decrement of overall survival. And so this is why we're now really trying to improve the quality of life for these patients and not just the survival, which is something that is, I think, very, very, very important for these patients. So how have we done this? There have been many studies that have been undertaken to try to help this, including some from Su Yam. This is the schema of HN002, where she randomized patients essentially to getting cisplatin radiation versus radiation alone. The radiation alone arm is not standard of care. Cis with low dose radiation at 60 degrees also not standard of care. So this is not a phase 3, but rather a phase 2 trial, randomized phase 2. And it was going to be compared to the standard of care with cisplatin and chemoradiation essentially at high dose. And what was found is that the progression-free survival of IMRT plus cisplatin is about 90.5%, which is good. In the 2-year progression-free survival for the IMRT alone arm was 87.6%. So you could see a bit of a decrement here. And this decrement was significantly less than the standard cis-RT that we would give at 66 or 70 gray plus radiation. And therefore, this was considered a rejection of the null hypothesis, and the trial essentially was negative. Right? So we could not de-escalate. Now, around the same time, RTOG 1016 came on, where there was a phase 3 trial of radiotherapy plus cetuximab versus chemoradiation with cisplatin. So here's a randomization. Patients get stratified and randomized to accelerated IMRT with cisplatin versus accelerated IMRT with cetuximab. And the idea here was that cetuximab, because it's a targeted therapy, should therefore have less toxicity when compared to cisplatin, and the patients, if they had similar outcome, could then be de-escalated. And this was a huge trial. As you can see, 549 patients. The trial kept getting extended and extended and extended through RTOG. And what this ended up doing then was resulting in an interim analysis. And what we ended up finding was that the overall survival was actually worse in the cisplatin-based, in the cetuximab-based group, and therefore cisplatin-based CRT is still king. And so cis-RT is still the standard of care. And now this has become now validated by yet another study from Hisham Mahana in Birmingham, which showed essentially the same outcome. And so we, for a long time, thought that we were doing a good job by treating people with cetuximab and platinum in an effort to try to de-intensify therapy and maintain their survival. But in the HPV-associated cancer patients, this was actually a bad outcome and a negative thing. So what do we do now in the field? We have now pivoted to try to use surgery to de-escalate the care for these patients. And so patients who can have surgery, usually transoral, so we no longer do the big lip split, mandibulectomy, the stuff that Peter and I trained at Pittsburgh on with Dr. Myers, and open surgery is now not considered as much of the standard. We now resect these patients using transoral surgery. And doing so, we can stratify these patients now into either low risk, intermediate risk, or high risk disease. Those patients that are low risk, that is negative margins, 0 to 1 lymph node, no other risk factors, can go on for observation. And this has been looked at in arm A of ECOG 3311. Also, the first arm of Pathos, which is a trial that's being run by Terry Jones in Liverpool. And then the best of trial by Christian Simon in Lausanne. That's the group that's being evaluated, or this group is being evaluated in those trials. Then we have the adjuvant RT alone can be used potentially for the intermediate risk patients. These are patients with 2 to 4 metastatic lymph nodes. Maybe they have a lymphovascular invasion or perineural invasion. They might have close margins, but do not have gross external extension. And in fact, in many of these trials, less than 1 millimeter external extension has been considered as an intermediate risk factor, so a small amount of extranodal extension. And these patients are being treated, were treated, I should say, in ECOG 3311 with the ability to de-escalate their care from 60 to 50 gray. That was the main question at hand. And in Pathos, they're once again being evaluated as well with a de-escalation of therapy. Now, the patients that have high-risk disease, that is positive margins, gross external extension, here we're calling it greater than the millimeter is considered gross, or multiple lymph nodes are considered high risk and is subjected to adjuvant CRT. Now, we have to remember that adjuvant chemoradiotherapy for these patients really comes from the Bernier and Cooper trials that were published in 2002 in New England Journal of Medicine. And those trials were really heavily biased by the HPV negative cohort, right? So if you have HPV negative, then those are the patients where chemo was added to radiation for the group with positive margins or external extension. And even in that sense, the actual effect, the actual delta that was given from that was relatively modest, about 8%. So that became standard of care because we had nothing else to do, and so we had to add that on. But in the context of HPV positive disease, does that really hold true? We don't know that. We just use that as dogma. So what Pathos is doing is actually randomizing those patients in that really what we call high risk arm to chemoradiation versus radiation to see whether this is actually a biology of the disease that's bad or if it is actually something that's modifiable. Yeah. So that's interesting data, and we look forward to looking at that in the near future. Okay, sorry. Okay, there we go. So transoral robotic surgery followed by randomization to low dose versus not low dose radiation was the name of ECOG 3311, and this was led by my colleague Bob Ferris. This was published in JCO afterwards. And this is the schema. So these are patients that have resectable disease. The patients all go on to have transoral resection with any approach, but all transoral. That means it could be robot, it could be laser, it could be headlight, doesn't matter, endoscopic, but transoral. Then the patients that are low risk get observation. The patients that are high risk get chemoradiation. The patients that are this intermediate risk get randomized to 50 versus 60 gray. So neither of these is standard of care. So that's why this is not a phase 3, it's a phase 2. It's a randomized phase 2. And the patients were evaluated for functional outcome. So in this, what we find is that the patients in arm A actually have an excellent survival of 94% at 2 years. Those in arm B and C had comparable survival at 95 to 96%. So 50 or 60 gray did not make a difference. But those in arm D had worse outcome at 90%. So this is the bad group. So what can we do about this, right? What can we really learn about this, and or how can we extend it? So here's some other data of surgery where patients, this is from the Mayo Clinic. This is Mayo Clinic 1675. That was run by my colleague Daniel Ma, who's a radiation oncologist, and he randomized patients 2-to-1 to what he called DART, or docetaxel with accelerated radiation therapy, versus standard of care, which once again is cisplatin with radiation, that is a 60 gray, with cisplatin for patients with high risk disease, that is extranodal extension. And these patients, they all had surgery. And after surgery with HPV testing at the beginning, they randomized and then followed for outcome. And so the bottom line, though, is that here, even when you do this kind of interesting treatment, the patients that have low volume disease do well with this docetaxel and accelerated radiation. So this accelerated radiation, just to remind everyone, means that they're getting BID radiation. So twice a day they get radiation. So these are captive patients. So they're getting 36 gray, 1.8 gray per fraction. So essentially you can finish the whole thing in roughly 2 weeks. So within 2 weeks, all the radiation's finished. Pretty fast, so that's great. Now, the problem is that the patients that were in that same arm D, external extension, multiple nodes positive, had poor outcomes. In fact, their distant metastasis rate was 40%, very high. Now, is this because it's docetaxel versus cisplatin? Maybe. But it's also interesting that the patients with this high-risk disease do so much worse despite the therapy that they're getting. Whether it's cis radiation or docetaxel radiation, they're not doing well. So this raises the question, is there something different about the biology of the disease? But for those patients that are in this intermediate risk group, they can get even further de-escalated, in my opinion. And this is a study that I started at the University of Pittsburgh with Bob Ferris before I moved. And I hope to reopen this trial here at NYU, where we can operate on patients with transoral surgery. Low-risk patients can get observation. High-risk patients get CRT with radiation and cisplatin. And this is the Dahanka protocol. So once a day, one day a week, they get BID dosing. So you can shorten it a little bit, but not as aggressive as full BID dosing. And then the intermediate risk patients are actually getting de-escalated to 30 gray instead of 50. So we keep going down on the radiation. This study is about halfway accrued, and hopefully we will have full accrual and completion in another couple of years. Now, we know that the technology keeps changing, this robotic technology. And so how does this technology now help us to personalize the care? Because I said most of these trials were using surgery that was transoral by any means, whether it was cautery or endoscope or robot, it didn't really matter. So what can we do here to make a better outcome and a better impact? And that's really what we would like to get to in the very near future. So these are the technologies that are currently available, and this is the latest technology on the market. This is the DV5. This is the 5th generation of the Da Vinci robot. I've just done the first few cases with this technology. And what's interesting about this technology is that you can actually use the force feedback instrument. So this particular version of the Da Vinci lets you know when something is hard or soft by touching it. And so the force feedback allows us now to be able to tell a little bit better. Those of you that do robotic surgery know that often we just look and we try to see where the tumor is. It's very hard to touch and feel where tumor is, which is what we do in open surgery. So this force feedback system is really important, and I think is going to be interesting, and we're actually evaluating this now with the Da Vinci 5. And how can we use these new technologies? So here's another new area that I'm doing in the US. I know that in Asia, it has been popularized quite a bit, as well as in Brazil, the use of the remote access robotic assisted neck surgery. And so this is a very interesting approach. Professor Go has done quite a bit of work on this. I'm sure everyone is familiar with that. But we've been doing this in North America for the past few years. And this is kind of what the surgery looks like. I won't bore you with this because I'm sure you've seen many beautiful videos from Professor Go, but we start with the retroauricular incision going to the hairline. We no longer have to do the preauricular one. We elevate the skin, and then of course, we identify the nerves, the 11th nerve, etc. Traditionally, the robot is then docked, and then the dissection is completed of levels 2, 3, and 4. And you can even go to 5, and you can, of course, do level 1. And this is a very old video when I was using the Da Vinci SI robot. And now with the DV5 or the XI, I think we can get much better exposure and much more elegant dissection with the wristed technology. With using the harmonic scalpel, this was not ever quite as good for me as I would have liked. But I think we can do very, very interesting things with this technology. I look forward to seeing it develop more and more in the future. And so here we have the completion of this dissection off of the strap muscles. I'm just going to forward this a little bit to get to the very end here. And we can see that at level 4 is taken off. Once it is, we can now see very nicely the complete removal of the packet. And then this allows us to have a very nice dissection of the transverse cervical, the floor of the neck with the phrenic nerve just over the scalenes. Here's internal jugular vein. Here's your 11th nerve, the posterior belly of the digastric, and a very nice comprehensive dissection and a very acceptable cosmetic outcome for these patients shortly thereafter. Now, one thing that we're noticing is that it's not merely the cosmesis, but these people actually look very, very good, and I will talk about that a little bit. But we recently published the 5-year oncologic survival for these patients. So this is comparing the remote access or robotic neck dissection in this group, this line, the red line, versus the open neck dissection. So this was 30 open cases versus 15 robotic assisted neck dissection cases, all with 5-year follow-up. You can see some of these are going out to over 90 months here. And so what we can find is that there is no difference in survival for these patients. And so this robotic assisted neck dissection is actually oncologically similar and yields comparable outcomes. Now, there's a noticeable improvement in these patients with lymphedema. They look really, really good because not only are you we are removing the lymph nodes in the neck, which will cause some lymphedema to begin with. But if you do not make that transverse incision through the skin lymphatics, then a lot of those can still flow through the skin lymphatics, and the people look so much better after this. And so I think that there's real value in this. In fact, we're studying this prospectively, and we hope to have some data on that in the near future. Now, one of the things that these sort of operations opened my eyes to is that not only can you do these with the robot, here's a child with a secretory carcinoma of the parotid and the tail of the parotid. Maybe you can see this. And this young boy was 7 years old, and his parents said, "Doctor, do you have to do a modified Blair incision with incision into the neck, on my child because he's so young? Could we, avoid that?" And I said, sure. In fact, we did this dissection, and we removed the tumor from the parotid, and we completed a full dissection levels 2, 3, 4, and 5 on this child, and he had 65 lymph nodes removed. All were N0. The carcinoma was completely removed in the parotid also, and this is what he looks like about 3 months postoperatively. And I saw him just before I left Pittsburgh. He is now taller than I am, and he is playing sports, and he wants to be a professional hockey player. So this goes to show you that although the access was thought about from a robotic perspective, in appropriate cases, you don't need to use a robot, and you can extend these indications by being thoughtful and by pushing the envelope in what we do. So finally, a little bit about the science of this. So when we talk about personalizing the care for these patients, what does that mean? That means delivering the right treatment for the right patient at the right time. And that's not easy to do. And so we need to be able to better define who the right patients are and what the right time is, because the treatments until now are not so different. So the surgery, we must remember, is not merely a way to operate on these patients, but it is in fact a way to learn about the disease as well. And this is something I really took away from Dr. Myers in terms of desire to show us as a community that we should be always thoughtful about how we manage these patients. And so one of the questions that came up in our mind was that arm D, those patients with multiple nodes positive and extracapsular extension always tend to do worse. So what is the genetics behind that was the question that we had. And in collaborating with two of my colleagues, Eddie Mendez, who was from the University of Washington, who unfortunately himself succumbed to cancer just when he was 45 several years ago, and Alex Harbison, who was his student and trainee, who I inherited and is now professor at Washington University, have gone on to do some really amazing things. He's gone to do great things. So Eddie, Alex, and I decided, why don't we pool our resources? We know that the survival is 90% for those patients. That means only 10% of those patients really have problems. So we have to pool centers together to be able to find an adequate number of patients to study. So how can we do that? So we combined our data from the University of Washington and the University of Pittsburgh. We identified tissues from the initial surgery, and then from the biopsy or salvage surgery for metastasis or nodal disease, et cetera, or local failures. And we subjected them to sequencing, to genomic sequencing. And we did not only exome sequencing, but also transcriptomics. But when we looked at the exome sequencing, what we found is that we could look at the primary tumor and those who never had disease, or the primary tumors that did metastasize, and we could compare these two. And what we find is that there is a conserved mutation in this group of patients, and these mutations really look like a genomic variance of aggressive disease. And when we look at the most frequently mutated genes, what we find is that in HPV negative cancers, and this is known from the TCGA, we see KMT2D, caspases, PIK3CA, et cetera, coming up. And in HPV positive disease, KMT2D and a couple of other FGFR and a couple of other genes that are frequently mutated. And so what we find essentially, I'm not going to bore you with the basic biology, this is all published, but what we essentially find is that when HPV positive cancers recur, they behave and they look genomically more like HPV negative tumors. And so that's a mutational change that happens, and we don't know whether that's because of a clonal expansion or something else. And we're now working on that to look at that more and more going forward. However, the reality is that these mutations cannot really be altered. We don't have a way to CRISPR out these things right now in vivo. It doesn't work that way. So what we decided to do was to look at pathways that may be dysregulated by these mutations or these changes, and maybe we could do something to modify them. That was really the question at hand. And so what we sort of did was looked at now transcriptomic or RNA analysis. And when we looked at that, we tried to identify conserved pathways that are dysregulated. And what we find, interestingly, is that one of the hallmark pathways that's mutated or changed a lot in these is actually oxidative phosphorylation. So recurrent tumors that are HPV positive enrich their oxidative phosphorylation status. And those of you might recall that oxidative phosphorylation is the pathway that is driven in mitochondria through the citric acid cycle and the way that ATP is made. And this is controlled by multiple different subunits, but one of the first steps of this is complex 1. And this complex 1 can be inhibited by a very specific molecule that was discovered at MD Anderson. And so if this complex 1 could be inhibited, we said, well, maybe we can identify how to go. But how do you measure oxidative phosphorylation in patients? It's very hard to do. So what we did was we identified a biomarker for oxidative phosphorylation, which is this gene called NRF2. This is known to be a master regulator of OXPHOS, and we can now study it. And so what we find is that if you overexpress NRF2 in tumors, they grow bigger. And then if you inhibit NRF2 with this molecule IACS, especially in combination with cisplatin, you get great responses. And so this is a HPV positive cancer patient who was resistant to cisplatin. He had surgery. We took the tumor. We made a model from it, a patient-derived xenograft model. And then you can see if you give that patient, again, cisplatin, there's some effect, but not much. If you give this IACS molecule, there's a massive effect, and even more when you combine it. So we think that this is the way to target these tumors going forward. What about the smoking and drinking cancers? The bigger problem in Taiwan, I'm sure, oral cavity cancer. I just did a big oral cavity composite resection today. These are people that are here, hard to treat. People have specific amplification events that drive the biology of this disease. And so the problem is that despite I think maybe someone's not muted, but despite these technological advances that we have come up with, survival of patients is not appropriate, not what we want it to be. So we need to identify novel targets and pathways for this. So again, as I said, two different distinct entities, lots of genetic mutations. And my lab was one of the first to discover a novel gene that is amplified in these patients. It's called ANO1, and it's frequently amplified, and that means there's more copies of the gene and therefore more active components of this gene in patients with this disease. And this gene actually turned out to be a calcium activated chloride channel, which is very confusing because we don't think of this as being a common molecule in head and neck cancers. We don't think about ion channels as driving cancer. We think about other things. But it turns out that if you pay attention, you can identify some, serendipity, so like this one, early acupuncture. So I thought this was appropriate maybe for you, Sheng-Po. So the idea here is that, if you can open the mind, you might find something interesting. And so what it turns out is that this is a calcium activated chloride channel. So it's a chloride moving agent. It turns out chloride is sequestered and stored inside lysosomes, because that's why lysosomes are acidic, because they have hydrochloric acid. And that this lysosome is important not just for capturing chloride, but also important for pushing things out of the cell, something called exocytosis. It pushes drugs out of the cell. And this ion channel that we identified affects both lysosomal exocytosis and biogenesis. and that by inhibiting the lysosome with a drug, very simple drug, hydroxychloroquine, which we use to treat malaria, we use to treat rheumatoid arthritis and other diseases, you can actually synergize with platinum and you can cause a big effect. And again, looking at a patient-derived xenograft model, if you add chloroquine, you can get a massive response in terms of adding this chloroquine plus cisplatin. So we think that this may be a way to move the field forward as well, going into the future. And I'm going to skip some of the basic biology here, but essentially this molecule activates a molecule called beta-catenin, which can drive things forward. In fact, a company from Japan, Prism Pharmaceuticals, now has an inhibitor for beta-catenin, this PRI-724, and this may be very useful in the context of these cancers and may be worth exploring going forward. And we are planning for that in the near future. And this is our proposed biological model. But one of the really other interesting developments in the field is that the field has really changed a lot because of the addition of immune checkpoint blockade. And this molecule, nivolumab, pembrolizumab, or other ones will actually cause a significant effect on survival of these patients. And most importantly, there is this tail at the end of the curve where patients can live for years after being heavily pretreated. So this is a cure, actually. This is not just nivolumab causing an extension of life by a few months or a few weeks. There's actually a significant cure for these patients. But how do we judge the cure? It's not very easy. We know that giving people nivolumab or pembrolizumab or durvalumab, which is an anti-PD-L1 inhibitor, they're very, very low response rates in general, but we usually give them to people that have high or moderate expression of PD-L1, which is the ligand for this drug. And so the question is, how is PD-L1 regulated? We say, oh, if the CPS score is this, you should give this drug, but how does the score get to that in the tumor? And really, to cut a long story short, this PD-L1 is regulated, the expression is regulated by this exocytosis. And we can block this exocytosis with drugs like apilimod, which is used to treat lymphoma. And by giving patients either apilimod, or sorry, I should say mice here, we haven't given it to patients yet, either apilimod or chloroquine, we can see a significant improvement in the response to anti-PD-1 therapy. This is in a mouse model. And again, this is what the mouse model, if you knock out PD-L1, you lose all the effect. So this really is a specific effect. And this is driven by the lysosomes. So by treating these mice with either apilimod alone or apilimod plus anti-PD-1, you can see a really nice effect and you can see an improvement in survival. So this shows us that maybe there are new drugs that can be combined with anti-PD-1 to improve the response rates and also improve the outcome for these patients. And in studying this a little bit more in depth, what is it about this PD-L1? It's not only the T cells that cause this effect, there are other ones. So one of my very talented students, Talani Olasakin, looked at a very large cohort of head cancer patients that were stained with different antibodies. These antibodies were allowed now to be imaged. And then what we found is that there were some specific markers that predicted poor survival in these patients, right? So we can make this cluster. We can say patients are either no evidence of disease, dead of disease, died of other causes, or alive with disease. So we can classify them by the image status. We can create these very complex and very beautiful mathematical models. And from this, what we essentially find is that we can stratify patients with a low risk of death versus a high risk of death with a very, very strong p-value in this cohort of patients. And what this is actually a characterization of an interaction between macrophages and the fibroblasts. And I've always operated on patients and said to myself, oh, this tumor is very sticky. It has a lot of fibrosis. And in the back of our mind, we know that those are the patients that usually do not do well. They have, if you think about it, the patients with a lot of desmoplastic reaction, fibrosis, they tend to not do well. But why is that, right? We never studied that carefully. So this is the first time, to my knowledge, that this data is making sense. And so what we did is we took human tumors, we extracted the fibroblasts, we extracted the macrophages from them, We took normal fibroblasts from some volunteers. We co-cultured them. And what we find is that there is a very interesting cytokine called IL-22, which is very heavily expressed from this interaction. And to skip a long story short, this interaction between the fibroblasts and the macrophages leads to the macrophages becoming more of a tumor promoting type environment. But if you have, and we can recapitulate this from a mouse model as well as from human patients, but if you actually get rid of those macrophages with some drugs like clodronate, which is not for human use, but it's a mouse drug, but you can actually see a very nice improvement in survival of these mice. So this is percent tumor growth inhibition. So when you give the clodronate, the tumors are more inhibited, right? And so they don't grow as much. And so we hope that this may be yet another way to move the field forward. So basically, when immune cells interact with these fibroblasts, they create both an immune suppressive cell type, and they secrete IL-22, which directly causes tumor growth and proliferation. And this immune suppressive myeloid cells leads to indirect suppression by blocking T cells and prevents the outcome. So ultimately, the science is really helping us to think about the biology, and hopefully this is the bridge that we'll use to go from, as I say, ignorance to awesome. This is the schism that we're trying to cross. And I think what we will be seeing in the very near future is that these immune therapies will no longer just be used as one-offs, but I think we will be using and seeing these more in the upfront setting. Today, I operated a patient with T4 tongue cancer into the root of the tongue, resecting the base of tongue with a suprahyoid pharyngotomy, really big oral tongue cancer. And we know that that patient is not going to do well. Bad disease. But what's really coming out is that this is a trial called Keynote 698. This is from Merck. This is going to read out in the very near future. And what this trial is showing is that patients who have treatment with pembrolizumab upfront for 2 cycles, 6 weeks before surgery, if they go on to surgery and then they get followed with either adjusted therapy, and then also they stay on the Keytruda for a period of a year, there is some preliminary data that these patients that have a response to this Keytruda actually have much better survival. And so this is not published yet. This is the feeling on the street, but I think that Keynote 689 will really change the paradigm for us in how we manage these patients. And so, this tail of the curve is really what's important. And if we can give these patients Keytruda or any of these drugs, I don't have any interest in one drug or the other, but something that can activate the immune system, we may help the patients to do better. And why should we do it neoadjuvant? Because it turns out that the draining lymph node, which we were all trained to remove and to cut out because it was bad, actually may not be only bad, it may have some good as well. The immune cells from that lymph node may get to the tumor and cause an immune response. And so we know that if you remove these draining lymph nodes and you give people Keytruda afterwards or any immunotherapy, they don't have as good of a response rate. If you leave the lymph node and then you treat them with immunotherapy up front, the response rate can be as high as 60%. Very high response. So this tells us that this immune mediation from the lymph node may actually be very good and very positive, and we must work on that to push that forward. And so this is some other data, once again, from Talani and my former fellow Marco Mascarella, who is now in Montreal, where we showed that patients who have any response to neoadjuvant therapy, that is therapy before surgery, have a much, much, much better survival if they have any biologic response at all. And so I think that there is more and more data in this way that will grow forward in the near future. And finally, here is some even cooler technology that's coming out. This is laser speckled imaging from various companies. This allows us now to look at perfusion and blood flow without having to give a contrast agent. So there's no need to give ICG. You can see this is just the animal, and you turn it on, you can see blood flow, you turn it off, you see a regular image. So this may be a way to delineate flaps, maybe a way to delineate the margins of tumors. It may provide us even ideas of how a tumor is biologically behaving. I'm not saying we have data on that, but these are the kind of things I think will help us to go from ignorance to awesome, because maybe we can then know who is the right patient to operate at the right time. Yeah. And maybe there's some people who you should not operate on because you will not help them no matter what, because they have bad biology of disease, and maybe we should do something else. So having said that, I think the future is bright. Personalized medicine is definitely changing the frontier of cancer care. And I think neoadjuvant immunotherapy will be a paradigm shift. I've left it here as a question, but the incorporation of technology that integrates biology to move this field forward is, I think, really where we need to go. And this is a great slide from my colleague, Dr. Claudia Chernea, who said, one who works with his hand is a craftsman, the one who works with his mind is a scientist, the one who works with his heart is an artist, and the one who works with all three is a surgeon. So with that, Sheng-Po, thank you for this great honor. I fondly remember our time in Taiwan. It was a bit slow, and then I think the last meeting got canceled because of COVID, but I hope to make my way back over to visit with you in sometime in the near future. This is back when I had black hair. Now it's all gray. So time goes, but congratulations on an amazing career. And I look forward to seeing even more things in a different way from you going forward. So once again, thank you for your attention. I will stop sharing.
Hello.
Good, wonderful. Can you hear me?
Yeah, it's been a wonderful talk, and I really admire you. You are really a surgeon. Uma, you are really a surgeon. From the clinical medicine, and then go down to the basic research and apply the basic research, some translational research, and really try to help the clinical medicine. And so that's what we should do. We look into the difference of the patient survival, the difference of the cancer behavior, and we try to find the reason. So we go back to the basic research, and then we're trying to find the answer. That's the way we move our field forward. So I think you are one of the best demonstration of how we work for the development of the clinical medicine today. And so I really admire you. You are not only a surgeon, so-called the craftsman, but you definitely you move the field forward. I wonder if there are any question or comments from the participants. I guess we have many participants, not only from Taiwan, but also from Singapore, from other countries. And I know Chimin is online also. So Chimin, would you comment on something? I think Chimin is our very common friends here. Yeah, Chimin.
Hey, hi, Peter. Hey, good to see you, Uma. And as usual, a very inspirational talk. I mean, it is just echo what Peter was mentioning about, surgeon not just being an excellent craftsman, but identifying when to operate, when not to operate through tumor biology, which you have clearly shown in some of the preclinical work. Maybe just a quick question: Is it now a standard to give neoadjuvant checkpoint for resectable but high risk head and neck squamous cell cancer, or is it still under the range of clinical trial research?
Yeah, currently it is still under the range of clinical trial research. I think once this Keynote 689 trial is actually going to be a registration trial for the FDA. That means that once that trial completes, they will submit that data to the FDA. If the data is positive and strong, then I think it will get approval. So once it gets approval, then it will be within the standard of care. But as of now, it's still experimental.
Fantastic. I think that likely probably would change the needle how our patients are doing, right? Because in the past decade, squamous cell cancers are still very highly lethal disease, you know. Even when I was training with you in Pitt, and I think since then, I guess that there's some movement, but it is still waiting for that big data that would change practice.
Yeah, and that's I don't mean to be too much of a a pessimist, I would say, but the reality is, we've been doing good surgery for a very long time. We do a good operation, we remove the tumor, we give chemo, we give radiation. We've been doing this for our whole careers, and we have not really changed the survival for these patients. And that's just the fact of it, right? I'm not advocating that we shouldn't operate. I still think there's a role for that. And I'm not advocating that we shouldn't give chemo or radiation. I think there's a role for those as well. But gosh, it makes you feel that we should be trying to do something different, because 50% of our patients are still dying. HPV negative, I mean, the betel nut chewers, the smokers, the drinkers, etc. And so we really should be able to give a better chance for them. And this, I think, is the first real, in my mind, a glimmer of hope to really change that going forward. So that would be very exciting.
Thank you, Uma. Looking forward to see you sometime.
Yes, I'll see you in 6 or 8 weeks, right?
Yeah.
In Singapore.
Yep.
In Singapore.
Right. It's nice to be back on to be able to travel after COVID. I feel we lost 3 years of our lives because of that. So.
And Uma, definitely we will get you back to Taiwan again. Someday, and yeah, we'll have some drinks together again. All
yes,
right?
I look forward to it. Absolutely. Absolutely. I'll see you in Miami.
All right. So thank you, Uma, for your wonderful lecture, and for all the participants, because we have limited time, but again, this is a wonderful lecture, and Uma, thank you for your support, your friendship, and we look forward to cooperate with you in the near future, and say hello to your beautiful kids and your wife. All right.
I will.
Have a good night for you. All right.
Yes, and I welcome anyone to come and visit New York. It's if in the US you can make a stop.
All right. We will. All right.
Bye.
So thank you. Yep. We'll stop the meeting here.
Okay.
Bye, Chimin. Have a good day.
Bye, Peter.
Yep. 就是很用心的，非常用心的。我们是不是还是要拍一下那个，跟大家讲，拍一下那个大家重新上线，大家把它看一下。